All right, welcome everyone to our meeting. My name is David Eisenman. I'm a physician at UCLA in the School of Medicine and the School of Public Health. And on the Aliso Canyon project, I lead the Community Engagement Core, as well as do some mental health research. So today, the purpose of our meeting is twofold. One is to present preliminary results of health outcomes research. Nadi Parat is going to discuss health outcomes based on visits to primary care and specialty care. So the results of that study. We do these studies, these preliminary study results, we give them in advance of sending the papers out to a journal for peer review. We present them to the community so that you can ask questions, make sure you understand the results, give you a chance to weigh in on it. And we want to make sure that you have that opportunity. And then after we do that, we're going to talk about some study updates, and we have quite a lot of study updates. So really, that's all I'm going to say. I'm going to turn it over to Lisa Balin, who's our facilitator for today's meeting, and she'll review some processes and instructions. Thank you.
Thank you, Dr. Eisenman. Good evening. My name is Lisa Balin. I am a facilitator with Sacramento State University, and I'll just be guiding us through our evening tonight, through this meeting. We've got a lot of material to cover, as Dr. Eisenman mentioned. We're going to have presentation, and then after each presentation, we're going to allow time for questions and discussion. Just want to let everybody know that what we like to do is to allow the presenter to get through the whole presentation, and then we open it up for questions. If you have a question along the way, feel free to use, if you want to jot it down, use one of the papers we have. If you need a pen, we have pens. If you just want to write your question while you're thinking of it. And if you're online, feel free to put a question in the Q&A feature, and I'll explain in a minute how to do that. But just know that we're going to get to them at the end of the presentation. So, and when we do get to the Q&A, we've got people obviously in the room and people online. I'm going to try to alternate back and forth. And if you've asked one question and there's some people who have questions and haven't had a chance, I'm going to try to let everybody at least get one question, before we repeat. If anybody in the room wants to ask a question, but you don't feel comfortable asking it yourself, feel free to write it down on this card with the green on top, and you can hand it to me, and I'll read it for you if you'd like. If you're also more comfortable, if there's just a question or a comment you want to leave for us, please just fill out this form, and we'll collect that and consider it after the meeting as well. Just want to make sure there's various ways for you to express your thoughts that you're comfortable with. I'm going to do my best to keep us on time to finish around 7:30. So thanks in advance for understanding if I need to move us along. Just want to mention, if anybody here is new to the study, and it's nice to see some new faces, I think, we have a lot of information about the study on our website. And we're going to put the link to the website in the chat for those of you who are online. And for those of you who are in the room, we've got a sheet with all of the website links. We have all the previous meetings recorded, so you're welcome to catch up watching those. The first meeting provides a good overview of the whole study that could be of interest. Our slides haven't been advancing. So we went through the agenda, just catch us up a little bit. Then for anybody who's new to Zoom or the Q&A feature, just want to give a few instructions here. So to access the Q&A, there should be an icon at the bottom of your screen, and you just click on that. We have this here just really for questions, Q&A. We just ask if you please use it just for a question and not for any other kind of comments on other people's questions. We haven't had that issue, but just want to mention it. And let's see. The chat will be sending messages through the chat to participants online, but it's disabled for chats coming in. If you're online and you'd like to make a question or, ask a question or make a comment verbally, what you would do is you would raise your virtual hand, and usually that's under the reactions icon. You click that icon first, and then you click the raise hand, and we'll invite you to unmute and ask your questions. So with that, just a few meeting guidelines. We've been following every meeting, and we really appreciate that, just to help us make these meetings comfortable and productive. And with that, I'm going to turn it over to Dr. Porat for our first presentation.
Thank you, Lisa. Let's figure out how to. Okay. So welcome. Nice to see you all. My name is Nader Porat. I'm a faculty member at UCLA Fielding School of Public Health. I lead the analysis of healthcare utilization data under the Aliso project. We're really pleased to share with you the findings of the new analysis that we have done on outpatient visits, and I'd like to acknowledge my co-authors that are listed here. As was mentioned earlier, all of these findings are preliminary. I'm sorry, I can hear an echo.
You gotta get closer.
Closer, okay, rather than further. Okay, so all of the analysis that you see here are preliminary. We're still doing additional analysis and making sure that everything is solid before we submit it for publication. So they could change slightly. So why are we looking at outpatient visits? I think to the evaluation of the impacts of the Aliso Canyon disaster include measuring direct impacts on health and health status, as well as indirect measures. Direct measures, we have already done a couple of analyses that have been published, looking, for example, on birth outcomes, looking at mental health impacts of the disaster on residents. And then there are other, we are using the healthcare utilization data to look at impacts that we cannot necessarily find data for otherwise. The healthcare utilization data also tell you about what people did. Sorry, skipped out here. Okay, sorry. We have already shared findings from a study of emergency department visits, if you recall, a few meetings ago. And that study was completed. It is currently in submission to a journal, and we received comments, and we have responded to those comments by the journal. We're hoping that we will see that paper in publication soon. The second major analysis that we're doing with these data is looking at visits to primary care and specialty care providers for evaluation and management of health conditions. So if you think about if people are exposed, they have experiences, physical reactions or other experiences, you would seek care. If it's really urgent, you might go to the emergency room. Otherwise, you might go to your primary care provider or subsequently go to a specialty care provider for services. So that's our goal, to look for those impacts. We are also looking at visits that are for other reasons, for example, treatment for different types of conditions, and we'll talk about that at the end a little bit more. So the premise that we had for this study is that people who were exposed to air pollutants released during the blowout would have had adverse health outcomes, and then they will seek care at their providers. So the research question or the study question here is, did residents in the affected community seek more outpatient care than residents in the comparison community? And then we are trying to look also at the reasons for those visits to the degree that's possible from the data that's available to us. That includes visits to primary care providers and visits to specialty care providers. I'll explain a little bit about the approach that we took to these analyses to help better understand and contextualize the findings. I think most of you are familiar with how we are identifying the affected community. We looked at the 5-mile radius south of the well, and you can see that highlighted here by these by the boundaries of the zip codes in the area in black. And then we have also identified a similar area we call the comparison community, which has similar population characteristics in terms of their demographics, and they also have similar environmental exposures. We are using zip codes in this analysis. That's because our data come in zip codes. We are not able to look below the zip code level. But what we know that some of the areas that we have identified, that, for example, here, down here, sorry, you can't see all the color that I see on my screen, but the area down here there are national parks and not populated necessarily, so some of the concerns about differential environmental exposures are allayed by where the actual population lives. When we did identify the population in the two areas, we were trying to make sure that we don't have people that have lived in both areas. So there were a small number of individuals that lived in both areas. We exclude them from the analysis because it could produce too much noise. Okay, and so the data source that we used for this analysis was UCLA health data. I think you can see them from here. UCLA happens to have major outpatient and specialty facilities both in this area as well as in the comparison community. And so we were able to get the UCLA health data. We compared the population that are patients of UCLA to the census data just to see what's the difference and how well the UCLA health data represents people that live in these communities. There are about 15% of the population of the residents in either community that are going to UCLA Health. We then compared some of the demographic characteristics just to see how different the two populations are with the residents, and we see that in terms of age, there are some minor differences, but when it comes to gender and race ethnicity, the differences are a little bit greater. UCLA Health does not have as much representation of the Latinx population. So that's one difference with the census data. So I mentioned already that we use the geographic indicators that are 5-digit zip codes. We can't get any finer than that in terms of where individuals live. We did try to reach out to Kaiser and the large insurance companies in these areas because they do have quite a bit of data. Unfortunately, we were not able to get traction so far, so we are sharing with you the results of the UCLA Health data. In terms of the what we have studied, we try to these data have diagnosis codes. So every time someone goes to the doctor, there are diagnosis codes that get recorded for the visit. So they usually, the primary reason for which the individual has gone to the doctor usually appears as the primary diagnosis code on these data. So we are using that as the reason for the visit. It's a proxy, it's not 100% aligned necessarily. That's the best that we have available. We then we do use these codes. They are organized by specific body systems. So, for example, for circulatory system or for different parts of the body. So we are using those major categories and showing you the data tonight. Some of these, I already mentioned, diseases of the respiratory, digestive, nervous system, and there are also codes for symptoms and abnormal findings. So if someone has gone to the doctor, but a clear diagnosis could not be made, providers can use these codes also. So it means that there was just not enough evidence at the time of the visit to make a clear diagnosis. We also analyze then these visits for primary care and specialty care separately. How did we conduct the analysis? We looked at the change in the rates of visits before, during, and after the blowout. So you can see how we have defined each time period. So this is the blowout. We try to use the exact dates to look at the visits that occurred during the blowout. It's a 4-month time period. We then identify some additional 4-month periods in the year before the blowout, and then additional 4-month periods in the year after the blowout. The reason we need to, and then we make comparisons. So we make comparison between what happened during the blowout and what happened in the similar time period the year before. It's important that you make those comparisons to the same time period, because there's a lot of seasonality. For example, during the blowout, it was the winter, flu, and cold season. So if you compare rates of visits here to a different time period that was not similar, it would look more or less, but it could be because people had higher rates of flu or cold. So we compare blowout period to the year before. We also continue to observe people for additional periods of time, all the way to the 1-year mark in this study, because we also wanted to see how long the increased rate of visit can be observed, and whether or not after a whole year the rates stay elevated, right? So when it comes to this time period, at the end of the time that we're observing, instead of making a comparison to the blowout period, we are interested in how is it different from the time before, when the blowout had not happened. So we can have a better idea of whether the rates actually changed or stayed the same a year later. Okay, so the other thing that we do in all of these analyses is trying to account for any other characteristics of individuals that could drive rates of utilization. For example, individuals that are older often have more visits to providers. So you want to make sure that when you're doing the analysis, you're not comparing adults and children, for example. So you have to include characteristics such as age, gender. Men and women frequently have different patterns of healthcare utilization. So they might go to the doctor more or less, depending on what kind of visit it is. We look at race, ethnicity, because as you know, there are other factors associated with race, ethnicity that determine patterns of healthcare seeking. We also account for insurance coverage, because people, as you know, your insurance coverage a lot of times decides whether or not you can go to the doctor, or there are other aspects of insurance that affect your utilization. And another important factor is what is the health status of the individual. People who may have chronic conditions may be going to the doctor more often. So you also want to make sure you're accounting for those. So I'm going to walk us through the findings. I'm going to try to go slowly. I apologize for speaking slowly. I'm hoping that is a little bit complicated Lots of different comparisons. I want to make sure we all can follow along. The first thing that we looked at was what were the patterns of visit over time. So here I'm not making necessarily those comparisons that I was showing you yet, but if you just look at what was happening over time, each one of these periods relates to a 4-month. Each one of these dots relates to a 4-month period. So you can see that before, all the way a year before the blowout, the rate of visits to primary care doctors in the affected community here, identified by green, was actually lower than what you could see on in the comparison community. But as time goes on, we come to the blowout period, the patterns change. So in the blowout period, the affected community members go to their primary care doctors at a higher rate than the comparison community members. And that rate remains elevated, as you can see here, all the way to the end of the observation period where they become a lot closer. They come closer together. The other thing we're looking at here is the specialty care visits. The affected community specialty care visit rates are lower to start a year before the blowout. They kind of increase during this time period all the way to during, and then they kind of stay below the comparison community throughout. So this is a high level, all visits to specialty care. Now we're going to look at further detail in a minute, which will show us the picture is a little bit different when you look at exactly why people were going to the doctor. So I'm going to go back here. Now, next thing we're going to do is make a comparison. The next slide is going to show you the difference the year before, during, and the year after. Okay? So now we're looking at what happened in terms of the actual number of visits in the affected community, which is over here. What happened to the rate of visits from during to before? So it is highlighted by this little yellow bracket here. And you can see that the rate of visits in between these two time periods increased by over 200 visits per 1,000. Okay, so it's an increase. It's a significant increase within the affected community. We look at the same comparison in the comparison community to see what was happening over there, and you can see that rate also increased, but by 100, a little bit over 100 per 1,000. So when you take the difference between the two, you see that the number of visits in the affected community increased more than the comparison community, right? So this type of analysis, also the scientific term is quasi-experimental, is the best form of, most rigorous form of study that you could do with this kind of data. And when you see that difference in difference analysis, it tells you that the increased rate of visits are likely attributed to the blowout, okay? So now we also look to see, this is the year after the blowout, and compare that to the year before the blowout to see whether those rates stay elevated. So if they increased by 200 in the shorter time period, they stayed up there. They were still higher at 150 visits per 1,000. And then we do the same comparison for the comparison community. That rate, so you can see it was 100 here. It sort of goes down slightly. The difference between the two, which is this purple, is a significant difference of 50 plus visits. So even a year after,
Shouldn't that be 60? 150 versus 90?
could be a typo. Thank you. Barry, can you check?
Yeah, I think it was 50 plus, so over 50.
Yeah, it's rounded up. It's rounded. Yeah. Okay, thank you. Okay, so now that we've looked at, these were all primary care visits, so we were looking to see, did people go to see their primary care physicians? And next thing that we looked at was, well, what were the reasons people went to primary care doctors? Of the results that you can see up here is the one that I was just showing you, but instead of just showing you those two differences, I'm showing you additional time periods. So this is the 4-month period during the blowout. We're also looking at the second 4 months after. We want to see if you may not immediately go to the provider. Maybe you have difficulty getting an appointment, or maybe the symptoms or experiences are not there yet and they show up later. So people may go to the doctor later. And so we're looking at that. And we're looking also at the next 4-month period. This is 5 to 8 months later. And then this is come a year later. And you can see these elevated rates. It kind of peaks a little bit more over here, but they're still higher even a year after. Now, when we look at what were the reasons for the visits, there are a number of significant findings. So the one that I'm going to first focus on is this one, going to the doctor for checkups, follow-up examinations, and screenings. Usually, if you see this code in the data, is because that was the primary purpose of the visit, and during the visit, the provider didn't necessarily highlight anything else as the reason for the visit, like they did not necessarily diagnose something new, but there were a lot more visits during the blowout in the affected community versus the comparison community. These are all comparative. And then the rate of those visits still was higher in the second 4-month period after the blowout. So that stays. But then when you get later on, those types of visits are no longer significantly more frequent. Okay. Another category of interest are these two, where individuals went to the doctor, but no diagnosis was made because there was not adequate information, most likely. And so then the diagnosis code that appears is symptoms, signs, and abnormal clinical and laboratory findings. And these cannot be classified in other types of conditions, okay? So these are unknown exactly what's going on. There's something going on, but it's not diagnosed at that visit. There's another group where people also went to the doctor and they got diagnoses of injury, poisoning, and certain other consequences of external causes. So I think between the two, if the provider did not feel that they have adequate information, they would use this code. If they make a diagnosis that this is probably because of some form of poisoning or external causes. We're going to take questions at the end if that's okay. We're going to take it.
It's okay to hold it if you want to write it down so you remember.
Because this is not correct information. Go ahead.
Yeah, well, I'll make a note of which slide.
And then the other, so we have these findings. The other findings are, okay, I forgot to mention that these diagnoses appear during the blowout, and same for these other symptoms. They don't show up later in the next time periods that we're looking at. And we also looked at these other categories, and we found significant findings, increased rate of visits for endocrine, nutritional, and metabolic diseases in the first 4 months after. We also found diseases of the respiratory system, which are here in the second 4-month period after, and then diseases of the musculoskeletal system and connective tissue. That also was significant findings. Let's move on to the specialty care visits. We looked at the patterns of these visits already, but here are further data that show you that when you look at the same time periods that we were looking at for primary care visits before, we see an increase in the number of visits for the affected community. We see an increase in the number of visits, specialty visits for the comparison community, but when you compare these two numbers together, those rates are not different. So we don't see overall, for all specialty visits, we don't see a difference in those rates. We also do the same comparison for the year after. Again, no significant differences. But when we do look at the rates of visits for specialty conditions, this was just the findings I was showing you a minute ago, additional time periods that we're not showing in that data, but they're here. We do see a number of significant findings. One of them are visits for neoplasms. Neoplasms include both benign and malignant conditions, well, malignant being cancer. And when we looked at the data, the percentage of visits that are noted, about 75% of them were malignant conditions. So we see increased rate of visits during and also in all the other time periods that we were looking at. So an increased rate for the affected community versus the comparison community. We then also have findings for endocrine and metabolic diseases. However, these findings have lower reliability because one of the conditions for this type of analysis was not satisfied, so we really can't attribute much to these findings, but we're showing you because that was part of it. Diseases of the respiratory system, visits to specialists later in the time periods, and then we see the same thing that we saw for primary care visits, which was visits for symptoms and signs and clinical findings that were abnormal but could not be diagnosed. Okay, so our findings showed that there were more primary care visits during and soon after the blowout. A lot of those visits were for checkups and general examinations, symptoms and abnormal findings not yet diagnosed, and injury and poisoning. Then later on, we see some additional findings for endocrine and metabolic diseases. This is primary care visits, musculoskeletal system and connective tissue, and respiratory system. And then we see the increased rate of visits for neoplasms, and then symptoms and abnormal findings, and finally for respiratory system, and that was in the after. We think that a lot of these visits are likely to be for existing or new conditions. Our data doesn't allow us to see whether or not this is the pre-existing condition or not. So these increased rates could be for either. However, when you think about it, it's less likely that these visits are for any individuals that are newly experiencing symptoms due to the blowout, because it's very short timeline, and usually neoplasms take time after exposure to show up. But some of these later months may imply that there is some of these might be new conditions. So our preliminary conclusions are that the affected community residents likely experience adverse health effects up to a year or longer following the end of the blowout, requiring health services that were at times advanced or more intensive, and that's referring to visits to specialty providers. And adverse health effects were likely due to exacerbation of pre-existing conditions, difficult to classify or diagnose symptoms, and general concerns for health given the blowout. The data do have limitations, most studies do, In this case, our data are from one health system, and there's possibility that the data are not representative of the experiences of everyone that lived in the community. We cannot measure health status or health impact directly. We're looking at visits, and we are trying as a proxy for health status. Some individuals may have gone to other providers. Even if you usually go to UCLA Health System for care, it's possible you may have gone elsewhere. And there is the issue of whenever you want an appointment, especially if you want a specialty appointment, you often have to wait. So the wait times mean that we may not have seen all the full impact of the blowout on healthcare seeking patterns because people had to wait, and sometimes some people may not have been able to get to the providers. We have plans for analysis of the neoplasms further. We want to look to see more detail on the type of neoplasms, for example, that people received or sought care for. And we're trying to do that analysis in a longer time frame as much as possible. We also are going to look at the impact on other forms of treatment, including visits, surgical visits, for example, to ambulatory surgery centers, and we'll hope to share those findings with you in the near future.
Thank you, Dr. Perrette. I'm sorry? Do you want me to go back there? Maybe you can stay here in case you need to, wherever you're more comfortable answering the questions. It's up to you. In case you want to reference the slides, okay. Too many computers on one podium. Okay, I'm going to make a queue of people in the room who want to make questions. And if you're online and want to ask a question, please raise your virtual hand or place your question in the question box. Could you tell me your name? John. John. And then Craig.
Helen. Helen.
I'm sorry?
Helen.
Helen. Okay, so let's get started with Matt. Let's just, we're going to get you a mic.
Hey, my name is Matt Pacuco, president of Save Porter Ranch. So that study shows that neoplasms showed up in a greater quantity, and you said something to the effect that it was too early to attribute it to the blowout, most likely. Have you also correlated this data to things like the BLADE root cause analysis report of that blowout, which showed that before the blowout and over I don't know how many years, there were 16 other what the size they were. We really don't know.
Okay, so I think, great question, thank you. What I was talking about is during the blowout, individuals in the Aliso Canyon area, in the affected community, had higher rates of visits for neoplasms. So what I was trying to say, and I probably didn't say it the way I should have, which is it is likely that individuals are going for potentially pre-existing neoplasms rather than new ones. So the time, like during the visit, within a 4-month period immediately, you don't necessarily expect to see a lot of new conditions emerging. But if anyone was experiencing or had cancer prior, they did definitely go to the doctor more during the blowout and following the blowout. So it is possible that, if you had pre-existing cancers, the exposure may have exacerbated your condition. You might have gone for additional visits to discuss with your provider, or you might have had additional physical symptoms.
Okay, but that just made it seem like, oh, this couldn't be from the gas facility. That's the initial impression I got.
Maybe, I don't know if the mic's on, but
Yeah.
It is.
I mean, you
we
just have-
didn't assess that specifically. So in this analysis, we're looking at the blowout. And we're thinking that it's unlikely that those cancers were caused by the blowout in this relatively short time frame of follow-up. It is possible that they were caused by some chronic exposure before the blowout. And, we're currently investigating all those possibilities, so.
Okay, and one quick question. Speaking of cancer, what about that cancer study with all the cancer data, which I'm sure Craig was going to ask?
We're going to do an update on that a little bit later.
Later tonight?
Yes.
Okay.
Thank you. There's a question in the Q&A box we're going to give a written answer to. It's on a little different topic. So I'm going to go to the next person in the room, which is John.
Yeah, it seems like the studies focused a lot on epidemiology and some symptomology, but not on causation. The frustrating thing for me is after I lived in the area, and in December, we moved out. I did testing on my wife, found out that she had very high levels of volatile organic compounds, benzene, ethylbenzene, toluene, styrene, hexene. I tested mine after, and this was through a testing with blood testing, basically, and used some provocative, so NAC, to help boost the glutathione and to pull it out of the fat cells, because that's basically where the toxic elements end up in the body. And my levels were extremely high in those areas too, in those same volatile organic compounds. Have you done anything on causation to find out if, by chance, it's the gas, those volatile organic compounds, or any other elements in the gas that caused those issues that we're experiencing symptom-wise?
I think you should take that.
Well, I guess on the causation question, one of the reasons that we're analyzing multiple health outcomes, there's a very famous paper by Sir Austin Bradford Hill that talked about the elements of causality. And those have been adopted by major agencies like the US EPA to determine whether or not there are health effects attributable to environmental exposures. One of the key components there is that you have coherency, meaning similar findings across different health outcomes. So we've looked at birth outcomes, the very start. We've also, now looked at a qualitative look at depression and mental health, and now these two healthcare utilization studies. We do have, and it was presented in earlier meetings, and I'll give an update on that, additional data that quantifies the emissions from the facility, but also from all other sources in the Los Angeles basin. And we have that going back to 2011. So we can certainly begin to interrogate it with respect to specific chemicals like benzene when we start doing that analysis. It's taken longer than we would have liked to get that analysis cleaned up, but as I'll report, part of that is that our scientific oversight committee is asking us to do more to ensure that the estimates are sound. So that's what we've been doing with that. But we also have a clinical evaluation that's ongoing, and that will have blood draws, respiratory function, neurological screening, blood pressure, height, weight. And with that, once we get the blood samples, we're sending them to Emory University. Dean Jones's lab is sort of the leader in doing this, toxicological metabolomics. That will tell us whether or not, at least in the current population, there's an ongoing increased burden, say, of benzene exposures. But it also gets at those intermediate states in the metabolism that can be indicative of heightened disease risk in the future. So that will, I think, begin to address the causality. And then I think the strongest evidence we're going to have on causality is when we look at the neonatal blood spots, because we'll be able to have those before, during, and after the blowout, and we'll have them in the affected community and other parts of the comparison communities. So we're working toward that. It's taken a long time and a lot of effort to get these data. I'll give more updates.
Got
But
data for you. I mean, some of my testing, because I think it's important to look at the tests from the individuals that were experiencing the symptoms, to find out if they did have toxic levels of those elements in them. Wouldn't that be the place to start? I mean, did anybody do blood tests? I tried to get it out there so that during the time that I was getting the blood tests, that other people would do it, but it was all new, and so it was very difficult for people at that time to understand that that's what they had to do. And I couldn't get the company to do it because everybody's kind of concerned about liability factors. But at this point in time, you're talking 11 years after, it's kind of going to be difficult to attribute any type of toxic levels in the blood now. But I do have them at that time. Again, I'm just one person. So I think it's going to be very difficult for you to correlate the causality, basically, of the toxic elements causing all these other symptoms without really knowing if they had them, if people really assimilated them into their systems.
yeah, I mean, I think the neonatal blood spots are a very sensitive marker. That's really, the mother and the baby communicating through the placenta. If there are contaminants getting into the mother's system, they'll appear in those neonatal blood spots. So we will have the ability to look at quantitative measures of both, the exposures and those intermediate states. It is a challenge to reconstruct exposures and to try and understand the effects of a disaster 10 or more years before. But that's part of the reason we're addressing these data. And these data they're sometimes called causal analysis data, because by selecting a comparison community that's well matched and then looking at their trends in time compared to what we see in the affected community, we are able to say that there's a very high likelihood that those trends are attributable to the blowout. So it's a form of support for a causal analysis. And as we go forward and we have more data on the actual exposures and get the blood draws, both contemporary ones and the neonatal blood spots, I think we'll be getting at a lot of those questions that you're concerned.
Those doctor visits that you're talking about, what did the doctors test? What were the labs? I mean, what did they pull? What did they?
Can I ask you to hold that for a second round, because we've got a bunch of people to get to, and I want to make sure everybody gets a first round. But hold that thought, and with time we'll get back to you. If not during this section, we'll try to do it at the end. Thanks for understanding that. We do have a question that was in the Q&A box, and I'm not seeing it anymore, but I'm going to ask the next one. So you answered that one, okay. In addition to UCLA Health, what about the post-blowout survey? Kaiser Medical Records or other health providers?
Okay, I mentioned that we did try to reach out to Kaiser. It is possible to do analysis with Kaiser, but the budget required for that analysis is quite huge. So that has been a barrier trying to look at Kaiser data. I don't know whether there's any reason to believe at this point whether or not the Kaiser patients are particularly different from the UCLA Health patients. It's possible that they are, but additional analysis of those, unfortunately, those other records has not yet been possible. We are doing the survey, and there's going to be information updates on the survey. The survey will provide self-reported data on individuals' experiences, so that data will also be available.
Thank you. We've got Craig next.
Hi, thanks for being here, everyone. I have a few questions. Just wanted to qualify first your control group or your what do you guys refer to it, the comparison group?
Comparison.
Okay, so the comparison group, let's just agree on one thing first. So the impacted group around Aliso, you demonstrated significant differences, statistically significant differences in primary visits for sure, right? Especially in a latency period, is not only during, but and showing latency issues. Okay. So I'm very curious because those are zip codes on the map that you showed.
Yes.
The zip codes were adjacent to the impacted community. Why was that chosen as the comparison or control group when in previous studies we advocated for far away from petrochemical? So in fact, if these are adjacent, so if you go to a non-petrochemical environment for your control or comparison group, the results could be significantly greater. How are you controlling for Aliso and petrochemical exposures by using adjacent zip codes? That's my question, and then I have another one after.
I think I'm gonna defer to Mike to talk about the patterns of this, what we know about how the blowout carried all of those hazardous pollutants through the air and where they might have landed. I think we had a presentation on that.
Yeah,
probably.
right. And they went south and they went somewhat west, and
Right.
that was right in the path of the zip codes that are in your control group, your comparison group.
So what I did want to tell you about what we have done in the study to minimize some of the differences in population characteristics between the comparison community and the affected community. So we are trying to address those differences and make sure that our comparisons are solid. But I think the question about the selection of the comparison community is something, Mike, you could talk about.
Yeah, so I mean, most of those zip codes do not have major petrochemical operations like fracking operations. If we went up higher into Stevenson Ranch, there's a lot of activity there. We intentionally avoided that, and we avoided the Santa
Can you go back to the
Susana-
map, please? Go ahead, Mike.
We avoided the Santa Susana field station. So I think initially what we looked at were the demographics. So tried to get a match there. We looked at environmental conditions like temperature, like air pollution, like routine air pollution, ozone and PM 2.5. And then we also looked at potential other environmental factors, like whether or not they were coastal. And we avoided coastal because we felt that was going to be very different. It does look like it's coastal, but as Dr. Pratt pointed out, most of the people are living well away from the coast in that zip code. So
it doesn't concern you that you have zip codes adjacent to the primary zip code of Porter Ranch?
yeah, there is a big mountain there that you drive over to go into Simi Valley, right? I mean, there is a major physical barrier. And then when we were defining the impact zone, we presented this in various meetings, but maybe I'll just reiterate. We looked at complaint data for odors and for symptoms, very little evidence that it was affecting that area. We looked at remote sensing data, so satellite data that showed where the plume was, and we didn't see any. We do have a few days where it blew to the north, but it didn't blow very far. So we don't think that it's affected those areas. And then we have our chemical transport model, which shows during the blowout virtually no impact on those control areas or the comparison areas. So with all that in mind, we're fairly confident that what we're seeing is real. It's not some artifact of the selection of the affected community versus comparison communities. We did do in the birth outcome analysis, we compared to these areas to other areas that were matched but away from petrochemical facilities and away from the coast. And then, all of LA County, all of California, you can't move those numbers. They're there, and it doesn't really matter what comparison group you put it against. In this case, we could expand the control area, but then we start to get into, there was a good match, say, around La Cañada, Flint Ridge. But the San Gabriel Valley, in a routine sense, is much more polluted than it is here. So you start to have all those differences pop up, And, you know, we were really trying to avoid that if possible.
I'll leave it at that. Just, does anybody know what zip code that is? Because it's really difficult, this map on the projection. Is that 91 or 93063, the one to the first? What, is that SEMI? What is that? Does anybody know? SEMI. Okay. Well, so you got Santa Susana. So I would, we'll move on. Thank you, Dr. Jarrett. But sensitivity analysis would be really cool to see away from the adjacent zip codes and see
Yeah.
if the magnitude of change on
I mean,
change
we looked
is
at going
even greater.
into Ventura more, but then you get into much more agrarian,
Yeah.
more pesticide exposures. So, but we can do sensitivity analysis and, you know.
I think that would add credibility to your study. So my other question, and I know we're pressed for time here, is you want 1 year out, and your diagnostic codes don't necessarily go there's a doctor, the MD, the latency diseases, the cancers, the leukemias. You did the tumor type studies, but what about blood disease, multiple myeloma, those sort of diseases? There's going to be a latency period. So wouldn't you want to be looking beyond 1 year because of the latency factor from the exposure?
We're going to talk about the updates on the cancer analysis, which actually does address that issue directly.
Yeah, I mean, the problem with going a lot farther out with this kind of analysis is a lot of other things could change. You know, if you go 5 years into the future, many other environmental and social factors could have changed. The population could have aged. So it's, you know,
But by having a control group, that takes those
Yeah.
sort of things into consideration. The event is still, you know, significant to the community,
I mean, I think-
proximity to it.
particularly what we're seeing for neoplasms, we should probably look at that and look at for a longer latency period.
Yeah.
The acute myeloma latency, based on the World Trade Commission investigation, not World Trade, the Twin Towers. Yeah, so that shows that, you know, acute myeloma and leukemias have latencies. The minimum latency period is about 1.5 years, so 18 months. So we could potentially see some of that showing up. We're also asking questions about whether people have had cancer when we directly survey them for our health survey, and those results are ongoing.
So we do have actually UCLA health data for multiple years forward. This particular look is looking at just the immediate impact, right? It's a short-term impact study. But we are going to, when we do the cancer analysis, we are actually going forward to all of the years that UCLA Health has shared with us to date, so we can follow along for a longer time period. But as Mike said, you know, the farther away you go, the population churn could impact the results. But we're still looking at those longer-term studies as well.
Thank you. I'm going to take one more question from online, and then there were 2 more questions in the room, and then we'll try to get to any remaining questions after. So the question online is, what percentage of residents does UCLA serve? Are Kaiser and other providers the majority providers? Did we answer?
So I think the analysis that we've done, and I mentioned earlier, is we looked at the census data. Census data tells you the total population living in these zip codes that we're looking at, right? So we compared the size of the UCLA Health data that they shared with us with the residents, and it's about 15%, roughly, for both the affected community and the comparison community. So the rest of the individuals could be going, Kaiser has large presence both in the affected community and the comparison community, and then there are other providers, I guess, you can see Facey Medical Group out there. But one of the biggest challenges with these data is that you do need to get comprehensive information, so our best option is try to pursue insurance companies, but they are not always willing to share data. And even if they are willing, if you get their attention, then there's also significant costs associated with it that sort of you have to take into consideration.
Yeah, I could just make a comment about Kaiser, because I've done 2 major studies with them on COVID and air pollution. And, you know, they have terrific data. They have a 25% market share throughout Southern California, so they have a bigger presence than UCLA Health overall. However, you cannot take any of that data out for any reason. So it has to stay in the system. So you have to pay Kaiser epidemiologists, data managers, statisticians. So let's say, you know, in one of the studies I did, the budget was about 1.2 million. Half of that went to Kaiser for a relatively short period when the pandemic was putting people in the hospital. So we had to make the decision, do we want to put that toward clinical exams and neonatal blood spots, or do we want to do a much, you know, broader population base in our administrative data? And, you know, because the cost would have probably been on the order for this kind of analysis and looking at many different areas around Kaiser facilities, it would have been at least $600,000 to $800,000 to do it. And, you know, that's, I think what we're getting from Dr. Pratt is a very good look at, you know, a major health system and how that was affected by the blowout.
Do you have access to the clinical information from those diagnoses, blood tests, et cetera?
I'm not sure. Dr. Eisenman?
Lab data?
We are not, you're not allowed to have individual level data, and so we would not, I think you're asking, can we look at a patient's level blood tests, and we can't examine patient by patient.
I'm going to ask if
Underneath HIPAA protection, non-identifying.
Are you asking about lab values, for example, or, yeah, the actual tests conducted? Yeah, that data is not available to us. I mean,
It is available if you don't violate HIPAA, correct?
it's they do have data. It's not the question that they don't have the data, but what they share for research purposes is often restricted. But we can take that back and actually have another look at the content of the data. I don't believe we actually have lab values in the data.
Thanks.
Yeah,
We're
it
gonna,
would
I'm gonna
be
move us on to the next.
For much more routine assays that, you know, particularly for the people where they can't identify a disease, they might give them a battery of, you know, 10 different blood tests, cholesterol, kidney function, that sort of thing. We are working with those data from Quest, where we obtained the data. We've determined that it's not a very good data set for this kind of analysis. What we have been doing is looking at whether there are acute associations with any of those blood tests and the blowout period. And also, you know, not the blowout period, but the actual contaminants, benzene, toluene, xylene, ethylbenzene. So that's an ongoing analysis. And
Thanks. Craig, I'm sorry, I want to cut this off.
Because I want to cut through the nonsense here.
I know, but I'm going to, one more sentence and one more response, and then two other people want to make questions.
The Quest data demonstrate that you can get the data done. You can get it done on an individual basis without disclosing who they are. So it is doable.
yeah, and I think, you know, for the question that came from the gentleman at the back, most of those tests are not going to be testing for benzene or any of those exposures. They're going to be standard battery medical tests that Dr. Eisenman could tell you much more about than I can. But it's certainly not something that. Now there was a recent study on the wildfires where Cedars-Sinai looked at all the emergency department visits, and they compared the diagnostic tests in the bloods to 10 years before. But that's only in their system, and they were working in their system. So the data providers at UCLA have not made that kind of blood assay or other biomarker assays available in the data that they supply to us.
Thanks. I want to make sure we have time to give two other people in the room a chance to ask their question and then move on to the study update. So Helen, I think you had a question next.
I don't remember 11 years ago if we had Kaiser Clinic or UCLA locally, but you should definitely look into Holy Cross Hospital, because I know what I saw in emergency room there, and Facey. I think majority of people had gone to those. But the comment I wanted to make when you were making all that report, I feel like it's false report because I don't know if you're aware, or if you're aware, you kept that in mind, that at the time Dr. Rangan from Department of Health had sent a letter to all the locals and clinics and all that, that do not test people and do not diagnose anybody that is coming here complaining about the gas thing. Refer us to the Department of Health. And calling Department of Health was, nobody was answering. There's no response. So that's why you don't have diagnosis. You see that people have gone to doctors more, but there's no diagnosis. And that's exactly, because I saw the letter myself when I took my daughter to emergency room at Holy Cross. I asked them to test my daughter for toxicology test, and at first they refused, and because I was getting loud, I was getting upset, the doctor showed me the letter. He said, because of this letter from Dr. Rangan, Department of Health, we are not allowed to do that. So you need to keep that in mind when you're doing any, giving the community this information, because this is false information you're giving to people.
So thank you. We do show you the results. There was one category only that was talking about the, sorry. Okay, so there are visits for many different reasons. We're showing all of those. So if somebody went for checkup or somebody went for, and their diagnosis for a visit was endocrine or metabolic diseases or diseases of respiratory system, they are what they are. I don't think anybody was told, according to what you're saying, that they cannot give a diagnosis of this person is suffering from asthma. That this category of symptoms and signs is what you're referring to, undiagnosed conditions, right?
Well, you said the visits were more, but no diagnosis, right?
For only one of the sets of different conditions that we looked at was this one. So there are some people that went to the doctor and that there was no diagnosis made, right?
Yeah, we're aware of that letter from Dr. Rangan.
Yes.
You know, it was
Yes.
certainly, it was an unfortunate letter.
Yes.
You know, there's just no way.
And that affected the community a lot. I mean, the outcome of everything has to do with that letter.
Right.
But I did want to mention also that we do have this paper that we presented at an earlier meeting it's been reviewed. We've responded to all the reviews, made revisions, big revisions to the paper. We expect it's probably going to get accepted, and that is comprehensive. That has all emergency department visits across all of California. So we have a complete population level data set. So, if there were a lot of admissions at Holy Cross, we'll be finding them if they happen in the zip codes that were affected or in the comparison community. So I'm not familiar with where that is, but.
Thank you.
I just might add, that category gets triggered when you go to a doctor's visit and the doctor can't say you go to the doctor for lightheadedness, and the doctor does not find a specific diagnosis, but still has to recognize that you that you're suffering from lightheadedness. So you get that becomes categorized as lightheadedness, which is really not a diagnosis, it's a symptom. And so that's how that gets into that category.
Yes, but when it's local doctor sees so many people coming to that office with the same symptom, and that symptom didn't exist before, and now all of a sudden, most of the patients are coming with that symptom, something is causing it. It's not just one person, it's just so many people. My own doctor told me, I know it's from this, Alicia, because she lives here too. But she said, I can't write it down because of that letter from Dr. Rangan. So that was huge. That letter was huge, and you need to really keep that in mind when you're doing any kind of survey.
There is remember, we also found some doctors registered it as poisoning. This category, includes, if somebody thought that this was because of exposure to some substance, it would have been here in this category. There's some results that support what you're saying, is what I'm trying to say. Absolutely. Absolutely.
Thank you. One more comment. I'm sorry I didn't catch your name. Did you have a comment back there? That you raised your hand earlier. Okay. And
we have
Gary,
one-
it's okay if I'm going to start with you on the next round because we're really running late. I want to make sure we get through at least presenting the study updates. We're going to have another round of Q&A after that, and I'll put you first on the list, Gary, just for people who have to leave at 7:30. They'll be able to hear all the presentation materials. So let's move to Dr. Jarrett and Dr. Hung Hu Liu, who's joining us online for the study updates. Oops, I'm sorry, I went too far. I went way too far. Okay, here we go. Sorry.
Well, I'm able to start with some very good news, and we put in an extensive report to the Scientific Oversight Committee. They reviewed it. We've had extensive comments that we've responded to. We responded to them last Friday, but they are recommending the continuation of the study. So, that was a big step, and I know many people were concerned that now that we're really going full on with the clinical assessments that they might cancel it. So by our contract, we have, sorry, I don't know, is that better? Yeah, so by our contract, we have to have another evaluation next December to determine whether we go to the final year of the study. I don't anticipate that they're going to recommend that we don't finish the study. And we're making excellent progress in many areas so that by the time we report to them, we'll have a lot of clinical exams, surveys, and the neonatal blood spots. So we also have ongoing exposure analysis. And, so this is a refinement of the chemical transport model that we presented. And what our Scientific Oversight Committee said is they wanted us to do more comparison to external measures. So there are 2 special surveys that the South Coast Air Quality Management does every 6 or so years. So we've got 2012, 2013, 2018, 2019, where they measure a lot of air toxics in the environment. It's called MATES, so measurement of air toxics in the environment. We're now comparing all of our measurements to those, or all of our estimates to those measurements, and we're making some adjustments to the models in response to that. There's nothing fundamentally wrong with the models, but we're trying to make them better. And then we also have validity studies where we're going to take what we found with the remote sensing data on methane and do a more systematic comparison of our chemical transport models. And we really do, and this is just one example. This is during the blowout. You can see, and I think this is benzene, or is that, yeah. So benzene is, I don't know why I can't, oh, there it is. I'm not seeing it on my screen. Benzene is significantly elevated in the impact zone. You can see over here, though, when we go into our comparison community, there's virtually no impact there. So that's ongoing, and we are comparing it to the retrievals that we got from the satellites. And we have Dan Cusworth and Miriam Marley are working on this. They're 2 of the very best people in the world. And they're going to work with Dr. Kleeman from UC Davis to see whether or not there are discrepancies between these 2 different assessment methods. Now, we have ongoing health analyses. Oh, sorry. Yeah, so I'm just going to turn this over to Dr. Hung Hu Liu, who's the co-PI of this study, and he's going to talk about the first 2 points, and then I'm going to update you on the last 2. Hung Hu?
Okay, thank you, Dr. Jarrett. Hi, good evening, everyone. I'm Hung Hu Liu, professor and the chair of public population health from UCLA. I'm one of the PIs. I'm going to provide some updates regarding the health data. Yeah, very sorry, I just have a schedule conflict and won't be able to be in person this time. And even though I was in all the 6 prior meeting in person. Okay, so the resident health survey. The first part, I like to talk about, update something about the cancer data, which is very important. I know, community is very concerned and about this. So based on the SOC recommendation, the additional more years of cancer data after 2021 were requested from the California Cancer Registry to facilitate with a long latency and the change over time in analysis. Multiple steps have already gone through, and the UCLA Technology Development Group, who actually coordinates this application, is in the final stage of negotiation with the California registry system to finalize the data storage, safety, and subject confidentiality issue. We received the email like about 2 weeks ago. We actually sent many, many emails, but the California Resident Health Survey, they have standard process, procedure, protocol we have to follow, wait. But it is in the final stage. We expect the data will be released to us soon, and we will report back to the community once the data available analysis is completed. As we mentioned, in the prior presentation discussion, we also have cancer data from the resident health survey, which not only have the information regarding this specific responder, but also actually ask about the cancer diagnosis of family members. Now, the resident health survey, we have address, we have accurate geo code, and for the California Cancer Registry, we also have, but that the geo code, but that has certain limitation. Is up to the 2-digit of accuracy, which is about the like 0.7, 0.8 miles range accuracy. So the resident health survey data eventually will provide additional valuable information for the cancer analysis. Next slide, please. Okay, so this one is about, our recruitment is ongoing. This slide actually basically shows what the envelope of the invitation letter looks like, which is on the left-hand side of the slide. If you receive something like this, please make sure to open and respond, because that will be an indication you will actually receive an invitation letter. And please also spread word and to your neighbors, friends, and in the area to do the same. Next slide. So this slide is kind of like a refresh for you about the recruitment strategy. We talked about this in a prior meeting. Basically, this shows we target 2,000 total for the survey responders, with 1,400 from the fact area and 600 from the comparison area. The invitation letters are mailed out to the selected potential participant in waves. We already talked about those detailed address-based sampling strategy. The letter including direct web link and QR code and other contact information. 2 reminder letters will be mailed out uh, to follow up if we do not receive a response. Next slide. This slide shows how to navigate from the resident health survey to the clinical assessment. The last question in resident health survey will ask, will you be willing to participate in clinical assessment in your community? If you choose yes, then you can directly go through clinical assessment consent process, or you can schedule a phone call with the study team to clarify your questions you may have before you signing the consent for clinical assessment. Next slide. We have some good news to report here regarding resident health survey clinical assessment, both recruitment and actual data collection. We made a significant progress. In summary, about 40,000 invitation letters were mailed out between November 25 and March 26. And in last week, additional close to 20,000 letters were also mailed out. Many people already responded, and most responses are being received as we move forward. More than 860 participants have already completely finished the survey. In addition, there are another about 120 people who also finished the survey, however, forgot to hit the submit button, which is beyond the 860. And we also have about 60 participants who actually partially completed. So if we put all this together, we actually already finished more than 1,000 participants for the resident health survey, which is more than 50% already. This is a significant the progress compared with the last community meeting. We also have a good consent rate for the clinical assessment, and more than 33% from the survey participants were eligible, actually already signed the consent for clinical assessment. We have already completed more than 130 clinical assessment, and many more have also scheduled for the coming clinical assessment data collection schedule. So with our recruitment and the data collection strategy, we are confident we will be able to complete the 2,000 resident health survey and 600 clinical assessment. Now let me turn the podium to Dr. Jerry again to continue update for the blood spot and the symptom and the other updates. Thank you.
Thank you, Dr. Liu. So the clinical assessments, we started them slow so we could work out and refine our standard operating procedure for people to run through the clinic. And now we're ramped up, so we're getting about 50, 55 per month. We're going to increase that to about 80. So we anticipate that all of the primary data collection will be done by approximately November of this year. And Christina Battiati, who is sitting in the room with us, has been working tirelessly nights and weekends and very early mornings to set these clinics up. Some of you would have already participated in them, perhaps, and they are usually being done in this community, in this facility, and then in Simi Valley, Woodland Hills, we have to use a hotel. We don't have a good site there. So, but we are getting a lot of additional recruitment, and once we have all that, we'll have all their blood work. We don't have budget for it right now, but we're also taking urine samples so we can bank them in a freezer. If we are able to get additional funding, we'll look at those. And as I said earlier, these will give true clinical assessments that compare the affected to other communities in the study. And we'll be looking at those biomarkers of exposure and intermediate effects, as well as standard things like lung function and cognitive screening. Now, more good news. So I guess we had a...
Can I just move this?
Oh, sure, yeah.
Sorry. So everybody can see the slides all the way.
Yeah, thanks. So we did do additional assessments, I think. So we're up to 143 of the 600. So, you know, we're making steady progress, and now that we have all our procedures in place, we're ramping it up. So we're recruiting a lot of people into this assessment. Now, the state biobank neonatal blood spots, that has taken us years and many letters and many applications, and we unfortunately got caught in the middle of a legislative change. So there was new legislation passed by the state that said there had to be extra scrutiny on future requests for the biobank. We got caught in that. We met with the director of the biobank and her staff, and we now have their agreement, and we'll be one of only 2 groups in the state that gets anything from the neonatal biobank this year. And so we've got 2,600 state biobank blood spots, 1,550 are from mothers living in the affected community, and then another 1,050 are for mothers in the unaffected or the comparison communities. And we're doing 1/3 before, 1/3 during, and 1/3 after. We're randomly selecting in the affected areas and in the unaffected areas, but then we're also oversampling adverse birth outcomes, like we've already looked at, because we know that the event contributed to elevated levels of adverse birth outcomes. Now, with these data, when we look at their metabolomic profiles, we'll be able to assess whether or not there were markers of exposure or intermediate states in their metabolism that could indicate future disease development or abnormal development of the child. So I think this is really, really good news, because, you know, this is the only biomarkers that we'll have before, during, and after. And because we have that, and we have this terrific lab, so we're expecting to get these by the end of May, and then Emory is going to produce the results by probably November. I mean, they're a very busy lab, so we have to get in the queue, but they are expediting this. And just, you know, for anybody that hasn't seen these are called Guthrie cards. So there are larger blood spots. We're going to be getting punches that will be about this size. And Dr. Jones and Dr. Ritz, who's on our team, have used this same size to do similar analyses in other populations. So with this, we're going to have these targeted and untargeted, meaning targeted at things like benzene, and untargeted looking at a lot of complex patterns in the data to see whether or not we see differences before, during, and after. And this is going to allow, as I said, specific assessments of exposures emitted. And if we find them in the baby's blood, it's quite likely that they were in other people's blood as well, right? So, so that's really good news. And you know, it's taken a heck of a lot of effort and time to get to this point, but we're happy that we have the full cooperation of the state now. We've also been working with symptom and odor reporting data that was collected by the Department of Public Health during the event, and this just shows the points, and then this is what's known as a density plot, so it shows where they were denser. And when we look at this density plot, and we start comparing it to those methane levels, we can see that there's spatially quite an obvious correlation there, right? We're getting a lot more symptoms where we have higher methane levels. So we're looking at this in terms of methane, but we're also looking at it for mercaptans and other contaminants. So those analyses are ongoing. They're being led by our colleagues at PSE Energy. So that's another major milestone to get all of that data. Because, you know, it wasn't clean when we got it. We had to really do a lot of cleaning to get to this point where we could geocode all of it. And we don't have the zoom out right now, but if you saw how many complaints there were outside of our impact zone, it's very minimal. So we don't see a lot from Simi Valley. We do get some. We get the odd person that's, living 20 miles away. Some people see it on the news and they just think, oh, I'm not feeling well, I'm going to report it. I'm not discounting that they didn't experience anything, but they probably didn't experience it from the leak. So, but we don't see a lot of evidence of those symptoms being reported in the comparison community. So we've got an ongoing list of studies which we're going to publish. We presented the risk assessment methodology. That's really close to being submitted. We're just waiting for those final runs of the chemical transport model so that we can put those into the methodology, but I expect all of this is going to happen probably by late June or early July of this year. We've got as Dr. Pratt mentioned, the emergency department visits as one indicator of health impacts. We presented that at meeting 5. It's, as I said, it's in review and it's been revised, resubmitted. And then we have the outpatient visits that Dr. Pratt and her team produced for tonight's meeting. We have a new methodological extension. This is really more of a statistical paper that Dr. Banerjee and his student are leading. And this will give us a better way of assessing the spatial patterns that come out of these difference in difference. Because if you recall when we presented this, it seems like a long time ago now, that those areas that had higher methane and higher contaminants were in this direction. And we had evidence that, we broke this into 3 different zones. This zone was seeing more adverse birth outcomes than, say, this zone. So, oh, sorry. Okay, let me just go up. Yeah, it's an awkward setup. Okay. Okay, yeah, so we can see here that, there's fairly strong correlation between the methane, but what we saw during our initial birth outcome study is that births that were happening in this area were more likely to be adverse birth outcomes than in this area. And our exposure models and remote sensing confirm that that's where the plume was most predominantly. So what we're doing now is extending the methodology so that we can look at more subtle and finer grained assessments of those spatial patterns. And we're also doing additional work so that it's interesting, these difference in difference models are very powerful, but they always assume an exposure area, like we've assumed it to be 5 miles to the south, or we did sensitivity analysis before with 6.2 miles, which is 10 kilometers. When we look at those patterns, we're not using the specific exposures that are generated by our external model. And there is not a statistical methodology in place right now that allows us to attribute how much of, say, the adverse birth outcomes or the ED visits were attributable to the leak versus other causes. And that's what we're working on with Dr. Banerjee and Dr. Molitor of Oregon State University. They're both leading experts in this area of spatial modeling. So we're going to have new methods that will allow us to really interrogate these data in a more complete way. And then we have, as you'll recall, we presented this in our last meeting. We had gas line monitoring. So this is the unburned gas that's going into people's homes. We had indoor-outdoor air monitoring of volatile organic compounds and metals. And then we did additional simulation modeling with what's known as a CONTAM model. So it's an indoor air pollution assessment model. And this paper and our analyses are basically showing that we've got higher levels of benzene in the gas lines that are in areas closer to the field. We've consulted with the PUC, we've consulted with anybody who will talk to us, Nobody has a good explanation for that. We do see higher levels in the benzene in the gas at Playa del Rey as well, where there's a gas facility. We just took one sample there as a control because that wasn't our main focus, but we thought we'd look at that. And those are among the highest measurements, so it's always close to the gas facilities. We've asked, and we could not get records that show us that, yes, this is coming from the Aliso facility or it's coming from some other supply location. But we were concerned about it, and that's one of the reasons that we added the indoor monitoring so that we could look at this. And what we're finding, and we reported it in a less statistical way, is there's virtually no correlation between what's in the gas line and what's in the indoor air of these houses. And then when we do the content modeling, even if we assume pretty high leak rates and we assume a small place like a 2-bedroom condominium, we did it for 3 sizes of houses and 3 different leak rates, that in no instance would we expect to see those benzene levels indoors moving much more than 0.1 or 0.2 part per billion. So not a really substantial change. The same group, PSE Energy, just published a paper based on data in the UK where they get their gas from the North Sea. That is very high in benzene, and their simulations suggest that that could be affecting millions of people in England and Scotland to the point where there would be substantial increases. But we don't see that here in any of our analyses. So we're creating this paper that brings them all together and tells that story. So that's the update. And then if you wanted to do the evaluation online, you can see the website.
Thank you, Dr. Jarrett. And thanks, everybody, for sticking with us. I know we're going a little bit past 7:30, but we want to make sure we have enough time for questions and answers. We're going to open up again for questions. Before we do so, as we do with all our meetings, we're really just trying to track how we're doing with these meetings, how we're presenting the information, and providing opportunities for questions. So for those of you who are in the room, there's a form with a blue text on top. If you have time at the end, it's just 5 questions. We know everybody has survey fatigue these days. So there's also a scan code on the form, and we're going to put a link to it in the chat, and it's on the sheet here. So with that, I want to open it up again to questions in the room and questions online. I'm just going to take a moment to write down the names of people in the room who have a question. Gary, did you still want to make your, I had Gary from before, Helen, if there isn't anybody who didn't get a chance. Okay, great. And then Craig. Okay. There are 2 comments/questions in the chat, in the Q&A, and I think they're similar, so if I could read them both and we can respond. What can residents do now to improve health outcomes after the blowout? We know we were exposed and are still looking for guidance now in 2026. It's interesting to hear about the studies of systems, but I want to know what I can do to counteract effects and extend my life. The second one I'm going to read, I think it's similar. Those of us who had adverse effects want to know how to improve our health, respiratory weakness, mental health, depression, cancers, etc. Is there any information or guidance available related specifically to the chemicals we were exposed to?
The general guidance for anybody at this 10 years after this kind of exposure would be the best things you could do, and I would say this to you both as the researcher in the room, but also as a doctor who sees patients, is taking care of your health in the ways that you take care of your health now, but being very, attentive to it. So most of the difference is going to come from your current diet, your current exercise, your current, all the things that your doctor is currently engaged in trying to get with you to improve and to do our best for our health. Those are the things that are going to make the biggest difference in our health 10 years after we've been exposed.
Okay, and there was one part of the question, is there any information or guidance available related specifically to the chemicals we were exposed to?
Well, I mean, I think that, now this is not speaking as a doctor, but, you know, the cancer biggest concern is the acute myeloma. So you may, you know, want to consult with your physician and say, I was exposed to high levels of benzene. The disease might still be in latency and presenting. So you may want to get additional evaluations done that would at least alert you to the fact that, or alert your physician to the fact that you're at higher risk for developing some of these diseases. But specific things that you can do 10 years after, I think Dr. Eisman is right. It's the big determinants of health: weight, diet, exercise, smoking, alcohol consumption, all of those things that we know if we do them in excess or if we smoke at all, it's not good for us. So beyond that, I don't have any specific advice, but I think it's a really good question, and it's something honestly we haven't talked about on the study team. And I think having heard this now, we'll go back to literature, we'll talk to other physicians and people on our nursing team as well to see if they have any other specific guidance that they could give to the community.
Thank you. Okay. Gary, thanks for your patience. I know you had wanted to ask a question earlier. I appreciate you waiting till now.
Thank you very much. I don't believe I've heard anything about this. This should be a short question. Specifically, our pets. Specifically comparing pets who have been primarily outdoors during this event as compared to indoor pets and also wild animals. It would seem like the outdoor pets right next to the home where the Homo sapiens are at would be a big comparison because they're even more exposed outdoors. Thank you.
Yeah, I know I've worked with people in the Netherlands where they have huge veterinary clinics where they do very careful tracking of pet illnesses, or in agriculture where they're tracking the health of cows. And, you know, that you need the data, and I don't think in the United States we have really good data on that's assembled about pet illnesses or symptoms. But it is a really good idea. It's you know, something that's beyond what we can do in this study. But I think it's definitely an area that merits consideration in the future if there are other disasters, to look at the health of, you know, and also oftentimes children spend more time outdoors, so we're concerned about that, and we have ongoing analyses on autism spectrum disorder. Unfortunately, the year before the blowout happened, the state completely changed the way it classified autism. So those those analyses are very challenging because our ascertainment of the case has changed right before. So we see everybody going up, some groups going up at different rates than others, and it's hard to find a signal in data that's so noisy. But that would be another group that potentially spends more time outdoors.
Thank you. Helen had a question. Hold on 1 minute so everybody can hear you.
This question, Dr. Jarrett, doing the study, especially doing this assessment, especially the adjacent area, are you just only looking at residents, or they're looking at place of their work? Because some people live around here, adjacent, but they do work in the area, like my gardener, for example. He's here 8 to 10 hours in the neighborhood, but he doesn't live in this neighborhood. He lives close by. So that, I think, looking at the place of work is very important too.
Yes, definitely. Unfortunately, we don't have that on people that were here during the disaster. What we do have, and we've just received the data, is an extensive mobility analysis. Because I know there's a lot of concern in the community. Were there a lot of people moving out after the disaster? would they be the ones that were feeling symptoms and left, so that you're not getting a real population sample of the people that were made the sickest from the blowout. So we're working with those data. There are a lot of move-in and move-outs, and we have a huge data set that the consultant has just given us. But we don't have specific information on their work. What we're doing in the risk assessment is assuming that they commute for certain distances a day and looking at the sensitivity of that in terms of their exposure while they're in the car, because when you're in the car, you're right in the center line of the road where the pollution is often highest, but we don't have the occupational data. We are collecting very detailed occupational data as part of the residential health survey, and that's ongoing. And we have Dr. Wendy Robbins, who's an expert in occupational health assessments. But
20 minutes, but they're working here 10 hours, so.
yeah, I think from, my experience being out here every second day during the blowout from, say, mid-December onward to the end, there were not a lot of routine activities going on then where people were gardeners and coming in. I mean, there were workers represented in the lawsuit, the settlement, so people that worked on site as first responders. We're not able to access those data. There are court controls on that. There may have been something there because it's unlikely a company that's trying to make profits would pay $1.8 billion to have people not reveal that they're getting sick. So we don't know, and it is, if we formulated this study specifically looking at workers, it would have been a very different study, and mobility, daily mobility. So that's something that, it would be a different methodology, a different population. We made the choice to focus more on the general population of people that were affected.
Also, assuming the sickest moved out is not correct, because a lot of us are here that were very sick, but we were too sick to move.
Yeah, no,
we are still here, unfortunately.
Yeah, we don't know the health status of the move in and move out, but we want to know how many of them moved very shortly after. That was just a concern that was expressed to us in some of the earlier meetings by people in the public.
Thanks. I'm going to take, looks like there's a quick question online, and then we have Craig, and we'll try to wrap it by 8. So the question is, are you tracking PTSD from survivors of Aliso Canyon?
I think we do have a question on that in the survey.
Sorry, what?
PTSD.
PTSD.
Yes. There is a PTSD scale in the survey, and we are absolutely looking at that.
Yeah, and then the paper that Dr. Eisenman and his colleagues from NYU published earlier was focus groups trying to understand the experience, and certainly some of what they said would be indicative of depression or worry about the event, which is potentially a symptom of PTSD.
Thank you. Craig?
Thanks again, everyone, for being here this evening. As you can imagine, I mean, it's been a long time, and we do get impatient. And so the cancer study is seemingly incredibly elusive. If I understood Dr. H, right? Okay. He said you currently have data, if he's still online, maybe he can answer, to 2021. You currently have it, but the SOC has asked you to look at more current data, and now you're getting, well, blocked by the Cancer Registry Group, which is a very controlling group. I've worked with them in the past as well. And it just seems like this is so elusive that someone is blocking true evidence here. Are you prepared to go with the data through 2021 if you don't get data beyond that? Because there is, what, an 18-month latency on it, right?
Yes.
So you can't get 26 data right now. So you'll only be missing, what, 3.5 or 4 years if you
Yeah,
2021?
yeah. But that could be when a lot of the cancers appear, and that was a concern of our SOC, that they didn't want us releasing preliminary results until we had a longer run of data. I think, you know, Dr. Liu and his team have worked tirelessly to try to get that data. And, you know, we expect it's going to arrive fairly soon. I don't think anybody's intentionally trying to suppress data or information. It's more that these are very rigorous processes to get health data, and they're very difficult. And oftentimes, the government agencies that supply the data don't have enough staff. So it kind of goes, you know, into something that's, but I don't think there's any intentional blockage of the data.
Yeah, I'm still online. Yeah, thanks, Greg, for that question. Yeah, we have no, any intention to block anything. We actually tried very hard follow the SOC recommendation
Yeah, I guess,
to
Dr.
get.
Liu, are you still online?
Yes, I am. Can you hear me?
Yeah.
Oh, okay. Yeah. So we follow the SOC recommendation, to actually apply this. We applied last year, in around October. And, the process, they were actually, the CCR want a full actually application for this even, just like a few years data. But we pressed on them. We said we really want this data, soon because we already applied before. And now UCLA, the TDG group I mentioned is the technology development group, actually is helping us trying to go as a supplement, which will save a lot of the, application paperwork. That's what we heard. We now, the TDG group is in the final stage, negotiated with CCR, and trying to go with this as a supplement. Looks like it will probably go through this route, which will speed this up significantly, and hopefully we'll receive data soon. We received the email I mentioned earlier, like about 2 weeks ago. They actually, because we keep asking TDG group and about the status, they said, yeah, it is in the final stage negotiation, and they want us expect to actually get something soon.
We're trying, and, you know, we have to do what the SOC tells us to do because ultimately they determine where the study will continue.
Well, do you think the SOC will say no to the 2021 if you can't get the data?
I don't think they'll say no to that, but they're just very concerned about us putting something out before we have all the as much on the latency period as we could possibly get.
I agree. I mean, right. I would prefer to have more current data, but I feel like someone's holding the whole study hostage. So it's really unfortunate.
Dr. Jarrett, do you want to close?
We tried. Thank you.
We are.
Thanks. Do you want to close us out, Dr. Jarrett?
Yeah, well, I want to thank everybody for their participation in the meeting and their interest in the study. And we always get so many great ideas from the questioners. I know people are very attuned and informed, and we appreciate all of you for what you're contributing to the study. I know it's taking a long time, and we've talked about this in the past, that, we want to do a very thorough, defensible job. So we could rush through something and put out so-called junk science, but that's not our modus operandi. We're trying to put out the highest quality data because ultimately, if there are health effects and we find them and definitively show that and publish it in the peer-reviewed literature, that is going to be the strongest evidence you can possibly get. And that's what we want to give you. So thank you very much.